Thank you very much, Catalan. It's great to see you and a real privilege to join all my friends and colleagues in Romania. Thank you for the invitation. So my task today is to talk about new horizons in rheumatology, and the field continues to move extraordinarily quickly. Unlike the slides, which I hope will advance in a minute and are not at the moment moving extraordinarily quickly. So we may need some technical help with that. There we go. So there are my disclosures. And let's just start off by reminding ourselves of why there have been so many advances across the huge range of rheumatic disorders that we see. And of course, there have been a number of approved targeted therapies across the different rheumatic diseases, and these advances have come about in part because of understanding of pathobiology that's improved, and in part because of the availability of targeted molecules, either small molecules or biologics. And these are some of the key ones here: B-cell depletion, co-stimulation blockade that we're all familiar with, a whole host of originator anti-TNFs, but also anti-IL-1 receptor, anti-IL-6 receptor, anti-IL-17A, and these have been approved for different conditions, as you all know, anti-IL-12/23 and anti-IL-23. Small molecules include apremilast, which is a PDE4 inhibitor, and of course, we've had a number of JAK inhibitors now approved. So the landscape has been evolving, but if we look at drugs that are now in late clinical development in rheumatoid arthritis and juvenile idiopathic arthritis, of course we know that there are some approved, but filgotinib in fact has just been approved in Europe in the last couple of weeks. It's not yet approved in the USA. There are a number of Btk inhibitors for rheumatoid arthritis in development, and we'll look at some of the data in a bit. Of course, the most recent biologic approved was an IL-6 receptor blocker, sarilumab, but there are others in development, including anti-GM-CSF, small molecules targeting the NF-kappa B pathway, we'll discuss that briefly, anti-fractalkine, which has not been successful. And then in juvenile idiopathic arthritis, we see that a number of the JAK inhibitors are in development, and also sarilumab. And of course, the other area that's very interesting at the moment is IRAK4, and I'll explain all of that as we continue. So the point is that the landscape is continuing to move very fast, and that's not just rheumatoid and juvenile idiopathic arthritis. If we look at ankylosing spondylitis, again, we can see that the JAK inhibitors are in development and look likely to be approved. There's still one anti-IL-23 agents in development, although many have failed in clinical trials. We've got some new anti-IL-17s, some of them already approved, some are in development. And of course, for psoriatic arthritis, we have tofacitinib approved for some time, but upadacitinib likely to get approval, I think. And we have the anti-IL-23 drugs. There are several biologics targeting IL-23 specifically. And we have various new types of JAK inhibitors, including those targeting TYK2. And so we'll talk about all of these things today. And in the case of SLE, there are also some very interesting drugs. We have the anti-IL-12/23 inhibitors, we have JAK inhibitors, and also antibodies to the receptor for interferons, all of which have given some encouraging data in SLE. So let's focus first on the JAK inhibitors, and there are selective and non-selective inhibitors, there are competitive inhibitors and allosteric inhibitors. So let's consider what that means. Now, I don't want to spend much time on this because I think you all know it so well by now, but it's just simply to remind you that the type 1,2 cytokines signal through the agency of the Janus kinases, and as you all are aware, the Janus kinases work in pairs. And the purpose for reminding you of this slide is that depending on the precise selectivity of the small molecule that targets the Janus kinase enzymes, and the effect not only on the particular enzymes but the enzyme pairings, this is a very difficult thing to work out in vitro, but depending on those effects, you might have differential effects in terms of the cytokines that are pejoratively inhibited. And the consequence of that is that selective inhibition may allow differential profiles of cytokine inhibition, which might favor treatment in rheumatoid arthritis or spondyloarthritis. It might favor atopic dermatitis. It might favor lupus, or it might favor inflammatory bowel disease. And in fact, we've seen clinical trial data in every one of these areas. But my focus today is on the rheumatic disease. So I won't be talking about inflammatory bowel disease or dermatology. So just to remind you, there are two ways in which you could actually inhibit a Janus kinase enzyme. One, this is what the kinase enzyme does normally. It normally dephosphorylates ATP and phosphorylates the target, which is a STAT protein. And so there would be two ways in which you could interrupt this process. One would be with a competitive inhibitor, and all the agents that have been approved so far are competitive inhibitors of Janus kinases, where the drug, the small molecule, competes with ATP for the binding site. But another method, and I'm going to show you some preliminary data, is for allosteric inhibition, where you have a drug that changes the conformation of the enzyme and prevents binding of the STAT. So let's have a look at the data. Well, in Tofacitinib, as you're all aware, there was a massive phase 3 program, and I'm not going to talk about that today because it's very familiar to us all, and it's been approved in rheumatoid arthritis for a long time. But this is just to point out how large the program was. But if we turn our attention now to Barocytonib, which is a JAK1/2 inhibitor, again, you're all very familiar, I'm sure, with the rheumatoid program, and it's been approved for some time. But perhaps less familiar is the new data that's emerging on the right-hand side here around juvenile idiopathic arthritis. So there are several studies looking at the efficacy of JAK1/2 inhibition in juvenile idiopathic arthritis. Perhaps some of you are actually participating in these trials. And the slide we're looking at here is just to give an overview of the study details. So these are 44-week studies. They're recruiting a good number of patients, and it's estimated that the study should be completed in the summer next year. There may have been some delays because of the pandemic that Catalan was talking about earlier. And the primary outcome with this JAK1/2 inhibitor will be the time to disease flare. But you can also see there are a number of other important secondary outcomes that will really be crucial in understanding the benefit for our junior patients who have this very disabling condition. So why is it that we might consider using JAK1/2 inhibition in lupus? And I think it's worth just going back to basics and reminding ourselves of what we know about the pathobiology of lupus. So it's been known for a long time that the type 1 and 2 interferons are implicated in SLE, but it's if you look at the cartoon, you can see that the type 1 interferons include interferon alpha, the type 2 interferons include interferon gamma. And if that, of course, the JAK1/2 enzymes, if you inhibit those, they would prevent the primary signaling of interferon gamma, but they might also have some effects on the type 1 interferons as well. So interferon gamma specifically signals through the agency of Janus kinase 1 and 2. And here's the first data. This was published in The Lancet a couple of years ago now, but this was a phase 2 study in patients who were ANA positive or anti-double-stranded DNA positive. They had active disease by the SLEDAI-2K, and you can see it's a parallel arm study with a 1-to-1-to-1 randomization comparing placebo and the 2 doses of Barocytonib, 2 milligrams and 4 milligrams once daily over a 6-month time period. And if you look across to the right there, you can see that the primary endpoints with resolution of arthritis or rash did show a potentially clinically meaningful difference, although it has to be said it's a relatively small difference. This has been one of the challenges in lupus trials. And if you look at the secondary endpoint of SR14 at 6 months, again, we can see a statistically significant difference in terms of this outcome measure for the higher dose of Barocytonib versus placebo. In terms of adverse events, there were a few cases of zoster, as you might expect, and there were infections in all treatment arms, but numerically higher proportion of infections in the Barocytonib arms, but nothing really new beyond what we've seen in rheumatoid arthritis trials. But there has been new data regarding the long-term safety exposure of Baricitinib in rheumatoid arthritis, and that was actually published this year, just a few weeks ago. So I'll quickly take you through this. Now, because there's so much clinical trial data from the phase 3 studies, but also the studies that preceded them, there are a number of different data sets. There are the data sets where there's a placebo control period over 6 months, which allows you to compare placebo and the test drug. Then there are the extended exposure data sets without a placebo control, and the all-comers data sets where you look at all doses of baricitinib, and I will just show you the summarized data. So this is the long-term safety published in Lancet Rheumatology in the summer this year, looking at 7 years of exposure. And as with all these charts, they're a bit complicated, so I'm just going to summarize the key message. And really the one thing that stands out here, as with other JAK inhibitors, is that there is an increased incidence of herpes zoster with the JAK1/2 inhibitor versus placebo. But with respect to other adverse events, actually the profile doesn't look very different from placebo, although there are numerical differences. One of the most controversial areas that we're all familiar with is that of venous thrombotic events, and that arose from the RA-BEAM study, where in the placebo-controlled period there was an imbalance in the 4 milligram arm versus placebo, as you can see on the left-hand side. Try and get the pointer to illustrate that. But in fact, when you advance these placebo patients on the left onto active drug over on the right, we don't see a recapitulation of this imbalance. So I think it's still a very controversial issue as to whether there's a causal relationship between JAK inhibitors and VTE events. If there is, it seems to be a rare event, and it seems possible that it's related to the higher doses of drug. Now, upadacitinib, of course, was approved relatively recently in Europe. In my country, it's not yet available for clinical use, but we're expecting it to be available very soon. And this is just a reminder. I'm sure you're very familiar with the data, but again, there's a huge phase 3 program, including 2 trials in biologic refractory patients and also monotherapy studies in early disease and in established disease. But perhaps less familiar to many of the audience will be the ongoing studies in juvenile idiopathic arthritis, ankylosing spondylitis, and psoriatic arthritis. So just in brief, when it comes to JAK1 inhibition, there have been theories put forward, and I'm not entirely sure that the theories have been substantiated, but the idea is this, that we need to look at a dose response for efficacy and also at the dose response for safety. And if it turns out that there's a limiting threshold with respect to safety, this might limit the peak efficacy that's achievable because of the dose response issues. Whereas the theory is that if you look at a non-selective drug, that there might be a situation where, in fact, if you look at the dose that's limited by safety, that it might actually give you a relatively low point on the potential efficacy curve. And that's the case that's been made, whereas the claim has been that if you take a situation where the efficacy and safety curves are separated, then this might allow you to use a relatively higher dose, as illustrated here, and the consequence of that is that you might be at the plateau of achievable efficacy. Now that's the theory, I must emphasize. I'm not entirely convinced that the trial data supports that theory, but there is no doubt that for upadacitinib, there's a very impressive efficacy data set. So here is the Select Compare study that perhaps you're already familiar with, which was a placebo-controlled and active comparator-controlled trial. And you can see at a glance that the upadacitinib gave a higher proportion of ACR20s and DAS28 remissions than the case with adalimumab. And in fact, for the appropriate endpoints, there was a demonstration of superiority. For DAS28-CRP in the remission range, and we have to remember this is the least stringent remission, that it's obvious at a glance that adalimumab does very well and is distinct from placebo from an early time point. But what is very clear and really very encouraging is that upadacitinib separates from adalimumab from an early time point and remains numerically higher with statistical significance. And so if we look at the proportions of patients in remission by different levels of stringency, the least stringent being DAS28-CRP, right through to the very stringent Boolean criteria, it's clear that upadacitinib gives a very nice rate of remissions. So what about safety across this massive phase 3 program? I think it was one of the biggest ever phase 3 programs in rheumatoid arthritis. Well, here's the summary of the data, but again, to make it simple for us today, what is very clear is if you look at the higher dose tested in some of the trials, which was 30 milligrams once daily, there is an obvious increase in adverse events as compared with the 15 milligram dose. And this is why the 30 milligram dose was not approved for use in rheumatoid arthritis, whereas we had approval for the 15 milligram dose. And once again, we can see that herpes zoster, the signal is there, it's dose dependent, and even with the 15 milligram dose, there's more zoster than with placebo. There are other studies ongoing, and we're going to watch this space with interest. So again, there are juvenile idiopathic arthritis studies, and the primary outcomes in this first range of studies will be potentially pharmacological. So we'll see what the pharmacokinetics are, and if they're favorable, I expect we'll see further studies. In ankylosing spondylitis, there's the SELECT-1 study, and this is in biologic-naive patients. And again, just to highlight the key issues, there will be measures of a number of important points, including the ACR20 response at week 12. This is, in fact, psoriatic arthritis. I'm just going to go back to ankylosing spondylitis for a minute. For ankylosing spondylitis, it's the ASAS40, which is the primary outcome measure at week 14. And then there are a number of key secondary endpoints around function and other measures of disease activity. And in the case of psoriatic arthritis, the primary outcome will be ACR20 responses at week 12, and there'll also be measures of the more stringent ACR70 responses, and of course the skin measures, including the PASI 75. So there we are. You can see there'll be joint and skin outcome measures in the this particular study, the PSA1 study. Now, filgotinib is the newest of the JAK inhibitors. It is relatively select for JAK1, so it's termed a preferential JAK1 inhibitor. And there has been a large phase 3 program with 3 trials in phase 3 for rheumatoid arthritis and an ongoing long-term extension trial. But there is also a trial in ankylosing spondylitis and psoriatic arthritis in phase 2, and we can explore this data together. For rheumatoid, filgotinib achieved its approval in Europe just, I think, last week or the week before, so it's really hot off the press. If you look at the remission data for the FINCH-1 study, which has been submitted for publication but not yet published in full, but the abstract was disclosed, here you can see that both doses of filgotinib are better than placebo, and you can see that the 200 milligram dose once daily is in fact better than adalimumab, and although this is not adjusted for multiplicity, it is statistically distinct from adalimumab. One of the challenges for all these clinical trials is the choice of hierarchical endpoints, and they determine whether or not you can make the legitimate claim for superiority around any given endpoint. And very often we see a situation where superiority cannot be claimed, and yet there's a statistically significant difference between the comparator and the test drug, which is a peculiar state of affairs. In Finch 2, this was the patients with an inadequate response to previous biologics. And again, you can see that filgotinib at both doses distinguishes from placebo. And of course, these are particularly refractory patients if they failed to respond to biologics. And if we look at the methotrexate naive patients in Finch 3, here are the ACR20 responses. And it just reminds us what a good drug methotrexate is in the green. In early arthritis, methotrexate is absolutely brilliant if the patient tolerates it, but nonetheless, the JAK inhibitor is better. And you can see the data there. Now, what about ankylosing spondylitis? So there's been a phase 2 study with JAK inhibition, and this is really very interesting because it suggests that the 200 milligram daily dose actually gives a greater magnitude improvement in disease activity than placebo. And I think we have to ask the question, what does this tell us about the pathobiology of ankylosing spondylitis? Could it be that this is inhibition of interferon that's making a difference? Because one of the primary cytokines inhibited by a JAK1 inhibitor is going to be IL-6, and we know that IL-6 receptor blockade is generally not effective in ankylosing spondylitis. And again, you can see there's a statistically significant improvement in the proportion of patients achieving a major ASDAS improvement. In psoriatic arthritis, the story is very, very similar. So there's a nice response in joints on the left-hand side with the ACR20. And if we now look at the DAPSA score, which of course is a more holistic score, on the right-hand side, again, you can see a statistically significant improvement. But a challenge with all these trials is there is a placebo response, and this makes, of course, interpretation challenging. Generally, the placebo response is less in psoriatic arthritis than it is in rheumatoid. So if we summarize efficacy of JAK inhibitors and do what you should never do, which is show an indirect comparison, but as long as I emphasize this is not head-to-head, this is an indirect comparison of 4 separate head-to-head studies, then I think it's very useful for us to get a ballpark idea, because if you compare each of these JAK inhibitors with adalimumab, to be honest, the efficacy looks remarkably similar. And in each case, there's a hint that the JAK-inhib is at least as good as the biologic anti-TNF, in some cases numerically better. So what about emerging new mechanism of action? Well, in the case of lupus, we have 3 interesting mechanisms, of which 2 are going forward. There's the antibodies to interferon alpha. Now, that has not been successful, and therefore the studies have been withdrawn. There are antibodies to the receptor for interferon alpha, and there have been mixed news about this, but the studies are going ahead. And there's the antibodies to P40, which means there's inhibition of both IL-12 and 23. And by the way, this was suggested on the basis of machine learning data based on what we know about the pathobiology of lupus. And here's the data. So looking at interferon alpha receptor blockade, the skin improvement is really quite remarkable. I'm sorry the pictures are not terribly wonderful, but you can see, I think, even despite the rather unequal coloring, that actually there's a remarkable degree of skin clearance in some patients with cutaneous lupus. For the joint outcomes, it's not quite such a marked difference, but nonetheless, the number of active joints decreases on anifrolumab, which is encouraging. Now, there were 2 phase 3 studies with contradictory results. In the so-called TULIP-1 study, the trial failed to meet the primary endpoint of a reduction in disease activity measured by the SLERI, which is the responder index. But the TULIP-2 study, which randomized over 370 patients to receive a fixed dose intravenous infusion, actually showed a positive result based on a different outcome, the composite lupus assessment. And I think this illustrates one of the challenges of lupus trials. They're very difficult to design, very difficult to carry out, and the outcome measure makes a world of difference as to whether or not there's an apparent confirmed efficacy. And here's the data for ustekinumab in phase 2. So this study was published a couple of years ago now, but again, it looks encouraging and I think really quite surprising for many of us that IL-12/23 inhibition gives a statistically significant distinction in SRI4 between placebo and ustekinumab. And the number of flares was greatly reduced over a 6-month time period. So again, encouraging data. Now, you may think that we've already got too many therapeutics in the armamentarium for rheumatoid, and I must say it's getting crowded. But nonetheless, I think all of us that sit in clinic and see patients know that there's still huge unmet need. And so the encouraging thing is that there's lots more trials going on. And one of the areas is around the Btk inhibitors that you can see at the top there. And Btk inhibition attenuates the signaling of downstream B cell signaling during B cell activation. And there are a number of Btk inhibitors in phase 2. Some of the data has been published and disclosed, and we'll go through that briefly. This was the most advanced study with Fenebrutinib, and this, in fact, was a complicated study because it took a mixture at phase 2 of DMARD refractory patients and biologic refractory patients and looked at a dose-ranging study, and it had a placebo-controlled and active comparator in the DMARD refractory arm of adalimumab, all on a background of methotrexate. And the primary endpoint was at week 12. And here's the data. So on the right-hand side in the red color, you can see adalimumab in the biologic refractory patients, and this is patients with ACR 50. So maybe the adalimumab's probably performing at about the level you'd expect at this early time point. And you can see that the upper dose of Fenebrutinib seems to give relatively similar results. And if you look at the TNF inhibitor refractory cohort, again, there's a trend towards an increased improvement in the patients on Fenebrutinib compared to placebo. But perhaps the study was underpowered to show statistical significance. So I rather doubt that BTK inhibitors as a monotherapy will be going forward in rheumatoid arthritis, but I think we'll see a lot more of them in other areas. Now, we've already talked a lot about JAK inhibitors in rheumatoid and in juvenile idiopathic arthritis, but all of them I've discussed so far were competitive inhibitors. And a really interesting molecule is going forward from BMS. That's something different. It's an allosteric inhibitor. So let's quickly illustrate that. If you look at the TYK2 molecule, it has two domains, a regulatory domain and an active domain. And rather than competing at the active domain, this drug actually blocks the regulatory domain and thereby prevents the active domain from working. And the consequence of this blockade, if you look at TYK2 signaling, would be that you might expect it to leave intact the signaling that goes through JAK1 and 3 because these heterodimeric pairings wouldn't be affected, whereas you would only affect the heterodimeric pairings where TYK2 is involved. And therefore, in theory, perhaps this might give a more favorable risk-benefit ratio. So that's the idea. You wouldn't affect the physiological signaling of some of the Janus kinases, where you would inhibit the pathological signaling, particularly associated with skin psoriasis, lupus, and psoriatic arthritis. And is there any data? Well, yes, there is. So this is data in looking at skin psoriasis, and there are trials moving on to lupus and PSA. And in skin psoriasis, to be honest, the data look pretty impressive. So here's PASI 100 in panel B, sorry, PASI 90 in panel B. And I think you'll agree with me that that looks pretty impressive. And down in panel C, there are even patients, about 1 in 3 patients who are achieving a PASI 100 at the higher dose. So this is interesting. And I think, again, we'll need to watch this space as more trials come through. But there are other mechanisms. Now, all of you know that anti-TNFs are very valuable drugs, and we've all become familiar with them. They've been approved for 20 years or more now. But what you might not remember is that the way that TNF signals is through the NF-kappa B pathway within the cell. And in fact, the NF-kappa B pathway, on the left-hand side of this cartoon, you can see the TNF receptor. There are two kinds of TNF receptor, and when TNF binds its receptor, you can't see very well because it's hidden behind the text, but it actually signals through the NF-kappa B pathway. And one of the molecules that contributes to this signaling is a molecule called RIP1. And a small molecule inhibitor of RIP1 has been tested in clinical trials. I can tell you that the manuscript has been submitted for publication, and you'll have to wait until it comes out before you see the results. But it's going to be very interesting to see what a small molecule might do that inhibits the pathway through which TNF signals. Now, clinical trials are very challenging, and I know many of you have contributed wonderfully to clinical trial programs. Another interesting cytokine has been fractalkine, and this facilitates the influx of pro-inflammatory cells in rheumatoid arthritis. And in Japan in particular, there have been studies that have looked at inhibition of fractalkine. The first data was an open label study, and it appeared that actually fractalkine inhibition worked rather well. Then a controlled phase 2 study was undertaken. Again, the paper is, I think, in print at the moment, if not already published. And in fact, it didn't show a benefit versus placebo. So clinical trials are difficult and frustrating. Often open label studies give us a false clue, and carefully controlled studies put us back on track. The other very new agents that are in development for rheumatoid arthritis and other indications target IRAK4. So what on earth is IRAK4? Well, let's look again at this simple cartoon of generic signaling for a number of different cytokines, and I want you to focus on IL-1 here. Now, the IL-1 signaling pathway is closely linked to another receptor that's just appeared by magic, the toll-like receptor. And of course, in the innate immune system, we know that TLRs or toll-like receptors are very important. So LPS, for example, signals through the TLL pathway. And IRAK1 helps signal through TLR and IL-1 just here. So IRAK4, I should have said. So IRAK4 inhibitors will block this aspect of IL-1 and toll-like receptor signaling. And the question is, will they help? Well, we've just seen the disclosure of a very interesting study, a phase 2b study. So this was Pfizer's IRAK4 inhibitor. You can see it's a dose-ranging study, and it was placebo and active comparator controlled. Now, the patients recruited were biologic naive, and they'd had no prior JAK inhibition, and the control was tofacitinib at 5 milligrams BD. And here's the data. Now, again, this looks a bit complicated, so I'm going to highlight some of the key findings. So if you look across this row for the SDI analysis, here's the placebo on the right, and you can see at a glance that all the doses of the IRAK4 inhibitor are numerically distinct from placebo. And in fact, they're statistically significantly different. So that's potentially encouraging that there is an efficacy signal with IRAK4. But now let's look at change in DAS28 CRP and the categorical ACR responses. Here's the table, but again, to make it simple, let me highlight the key results. So firstly, let's focus on placebo over here. You can see the placebo responses. Now let's look at the active drug, the IRAK4 inhibitor, and you can see the percentages of patients achieving an ACR 20 or an ACR 50. And now let's compare that with the active control, tofacitinib. And I think what you can see is that the IRAK4 is at least numerically better than placebo, but numerically not as good as tofacitinib. And that's also true at the more discriminating endpoint of ACR 50 here. So again, my suspicion is that with IRAK4, it may not go forward as a monotherapy in rheumatoid arthritis, but we'll have to see. There are a number of other IRAK4 inhibitors that are going into trials. This is the Pfizer phase 2 data looking at adverse events. And I'm sorry, I'm just going to go back to that for a minute. And basically the bottom line here is that there are no obviously new adverse events. But these are early days. GM-CSF has been known about as a target for a long time, and here you can see the GM-CSF receptor up on the right. Don't forget that Barocytonib also inhibits GM-CSF signaling, and so do some of the other JAK inhibitors to some extent. But there have been 3 molecules targeting the biologic molecules targeting the GM-CSF pathway, either against receptor or ligand. And the most recent one was in fact against ligand, and it's been known in rheumatoid that this could be important because it controls so many different aspects of rheumatoid pathology, including Th17 generation and M1 macrophage generation. So in brief, namilumab, there have been clinical trials in rheumatoid. I'll show you the data in a minute. And there has also been a clinical trial in ankylosing spondylitis. So I was lucky to be the chief investigator of both those studies. And this is the rheumatoid study, which we published last year. And you can see that there's a dose response for change in DAS28-CRP. And there's a response for the categorical endpoints as well, where namilumab, the anti-GM-CSF against ligand, distinguishes from placebo. But what we don't yet know, or is not yet disclosed, is the results in ankylosing spondylitis, and that study is being written up. So again, you'll have to watch this space. And to finish up with here, we used to have a comedy show in the United Kingdom called Monty Python. I don't know whether you've ever watched it in Romania, but the strapline for Monty Python when they began the show was always, and now for something completely different. And this is something completely different, because this is one of the first approaches to therapy which is completely non-pharmacological. And in fact, it's electrophysiological, because there have been several studies, some data have been disclosed, some are yet to be fully disclosed, where the vagus nerve has been stimulated. And in this particular study, you have to implant a device, a bit like a pacemaker, under the pectoral muscles. And then you put an electrode around the vagus nerve, and this is the efferent branch of the vagus nerve, and stimulate it. There have been other attempts to do this, which are in publication, where the tragus branch of the afferent part of the vagus is stimulated. But anyway, you apply an electrical current through this little device, and this is just a pilot study with 3 different regimes of stimulation of the vagus nerve, and also a sham vagus nerve stimulation. The study is very small, as you can see, so I think we have to be very, very cautious in reading anything into this, but it nonetheless is very interesting. Needless to say, there were some adverse events. So a serious adverse event included temporary vocal cord paralysis. This is always going to be a risk if you're fiddling around with the tissue by nerves that innervate the vocal cords. Other resolving adverse events included a Hornose syndrome. Again, not surprising, given that the vagus nerve was involved surgically. But there were no withdrawals, amazingly, due to adverse events, and no cardiovascular events. So this is a treatment which requires a fair degree of patient involvement to actually implant a device. But the data are very interesting, because actually about half the patients showed a clinically meaningful improvement in measures of disease activity at week 12. A couple of patients achieved remission, and erosion scores actually seem to correlate with response. So just maybe, but we have to be very cautious, this could be a new way forward. So maybe in the future, for our patients with very refractory disease to all the pharmacological interventions, we might think about a physiological intervention, but we'll have to see. So do be very careful in interpreting pilot data. So in conclusion, clinical research continues to move incredibly fast. So it's a great time for all of you to be in rheumatology, and I think you're all to be congratulated, because I know you've contributed so much to various clinical trials from your country. The recently approved small molecules, as we all know, target the Janus kinase pathway, and I think we're going to see more and more of Janus kinases as we go forward. But the availability of these new targeted therapies has really changed the way we think about the immunotaxonomy of diseases and the causes of disease. So to give just a quick example, IL-23 inhibition didn't seem to work in ankylosing spondylitis, and yet in psoriatic arthritis with axial disease, it seems to give a good benefit. So this is a completely new insight, potentially, and further research will be required to validate this formally. The future choice of best targeted therapy for a particular patient, I think, will be strongly influenced by the presence or absence of certain comorbidities. The EULAR recommendations, of course, for rheumatoid are very good, but really they also a little bit unhelpful in a way. If you fail on a conventional synthetic DMARD, what do you do next when you've got so much choice? And we need to think more and more about comorbidities. And importantly, as these new therapies emerge, we need to understand the risk-benefit ratio for the individual. And in my opinion, individuals should be able to be proactively involved in that choice as to what they think is an acceptable risk for the degree of incapacity they have from whatever rheumatic disease it is. So I'd like to thank you all. As always, it's a pleasure to join you, and I think I'm going to try and stop sharing my screen in case there are any questions. I'm not sure if I'm able to do that, but I will try. Thank you very much.
Peter, for your excellent. Can you anticipate a slowdown of current research for different novel therapies in rheumatology in the next future?
It's a great question, and I think it's going to be geographically variable, and there are two distinct aspects to this in my view. Certainly in my country, there has been a significant slowdown. We had to stop recruiting to clinical trials for about 6 months. We're now restarting with very strict rules. But that's clinical trials that were ongoing pre-COVID with a view to looking at rheumatic disease quite independently of any COVID-related outcomes. The separate issue that you'll be well aware of, and although I couldn't understand, unfortunately, entirely because my Romanian is so poor, but your very nice lecture earlier where I could understand the gist of some of the slides. Of course, there's been a huge flurry of activity around using many of these targeted therapies in trials for COVID specifically, because we know that the later phase of COVID that causes the mortality is related to cytokine storm, and many of our agents target various cytokine pathways. So we've seen rather disappointing results with IL-6 receptor blockers, as you know. There are ongoing trials with anti-GM-CSF, with anti-TNF, and with with JAK inhibitors, and it's too premature at the moment to show anything. And I think you showed data from the recovery trial where, of course, dexamethasone has been shown. And the other very interesting agents is the neutralizing antibodies that are going fast-tracked into trials. So I think it's slowing development and trials in rheumatic disease, at least in my country, but accelerating development in COVID-related indications.
And the second question is taking into account SARS-CoV-2 infection, but also secondary infections with various microorganisms. Do you think that we need to take this into account when judging the risk-benefit ratio for various therapies applicable for rheumatic diseases?
Very definitely, I think we do. I mean, from a patient perspective, there are a number of issues, and in brief, here's my summary opinion, but I'd love to hear your opinion as well. I think for any of the targeted therapies we use, there are, of course, risks, and they vary from one therapy to another, and there are benefits. But what we've learned in the last 6 months of SARS-CoV-2 is that whereas at the beginning of the pandemic, we were all very worried that the immunosuppressive targeted therapies may increase the risk for our patients, actually much of that fear has not been substantiated and confirmed in epidemiological studies. And the most important take-home message I think I have and communicate to my patients is that really the key is to keep the rheumatic disease under the best control possible, and that seems in fact to be important, and to greatly reduce the risk of the complication and even catching the virus. But nonetheless, patients have to observe all the sensible precautions about hygiene, social distancing, etc. Now, given that the apparent risk based on epidemiology from targeted therapies and either catching COVID or having comorbidity is much lower than we thought, the only confirmed risk is of steroid above 10 milligrams once daily. Given that that risk is lower, then I think our emphasis has to be around the other infectious risks that you mention, and we need to talk those through with our patients. What I think is disastrous is if patients actually stop their targeted therapy in the belief that that will protect them from COVID, and actually they end up in a worse situation from every point of view.
And one more question, it's related to recommendations for vaccination, especially flu 1.
Yeah, well, at the moment, I think it's very important that our patients receive the seasonal flu vaccine if they can, and other vaccines as per our various national guidelines. Of course, it's the case that any live vaccines one has to use with caution, but for the live attenuated vaccines, the trick, particularly for pneumonia and for influenza, is if possible to stop methotrexate for a couple of weeks prior to vaccination. That increases the chance of a good immune response to administered vaccine. If a patient is due for a scheduled rituximab, ideally get the immunization before the next scheduled cycle or before initiating rituximab rather than afterwards. But broadly speaking, I think where there are live attenuated vaccines, it's more important than ever to get our patients protected to avoid confusion and hospital admissions in the face of a pandemic.
Thank you very much. It was great. It was a big pleasure to hear you again, and we give you a very big online applause.